but you use FSM to assist. So when you can balance the energy centers, take trauma out of the solar plexus, tell the hippocampus to take a nap.
Yeah. And every repetition is sending a signal back to say, that didn't hurt, that actually felt good. Let's do it again.
Turn the vagus on so it will reduce inflammation in the brain of a PTSD patient. It was really interesting.
I think that created an environment where I was maybe more trusted with information because I wasn't part of the team. I think patients, especially in this day and age, need one-on-one time to look somebody in the eye and have somebody say, it's going to be okay. I can take care of this. This stuff is pretty easy for me, actually.
The vagus suppresses the immune system. I get worried about that every now and then. On the other hand, if you have an active infection, the vagus will notify the brain that there's an active infection, and the brain will turn the vagus off faster than you can turn it on. You got very little to worry about in turning on the vagus.
Thank you for subscribing to the Frequency Specific Microcurrent podcast. FSM is a breakthrough tool for medical practitioners who feel stuck with limited treatment options, especially for complex issues unresponsive to conventional care. FSM training is the best continuing education course for medical practitioners. Get our free introductory webinar at frequencyspecific.com/about or find FSM trained practitioners at frequencyspecific.com/find. Here's Dr. Carolyn Kim Pittis.
I think we're supposed to be able to adapt with change, right? There's
a rumor to that effect.
What we're supposed to do. Mike is too high.
Hi.
Hi. What have you been doing this week?
Seeing patients. And what's interesting is Monday and Tuesday, and today being Wednesday, I was more psychotherapist than I was FSM practitioner. But you use FSM to assist. So when you can balance the energy centers, take trauma out of the solar plexus, tell the hippocampus to take a nap, turn the vagus on so it will reduce inflammation in the brain of a PTSD patient. It was really interesting. And I never ran on time. Usually in the clinic, I'm within 10 minutes.
Yeah.
Yet no, just no. So it was interesting. And I got to do a psoas on somebody that didn't know she had psoas issues, but she had adhesive capsulitis in her hip. And the little voice in my head said, that doesn't make sense. It's probably her psoas. So I checked her psoas, and both of them were, 13 and 60 and 13 and 23. And it was fun.
Let's talk about a couple of those things already. So, because that's what we get to do. The more, and I've always had that athletic population. And I think I got busy with two things. One was the creation of the safe space, because I was never employed by a team. I've always been my own person where the athlete could come to me. And I think that created an environment where I was maybe more trusted with information because I wasn't part of the team. I wasn't part of that organization that would tell the secrets, that would rush an athlete back if they weren't ready.
That would use the secrets against the athletes.
Correct.
When it came for contract time.
Exactly.
You are the safe space. No, done that.
And it brought me back to that place when I was away last week treating. And when you're in a big environment, it's really exciting when you're in a big facility and there's a bunch of tables and there's trainers and there's therapists and there's athletes and there's any device you could imagine. It's Disneyland for
Yeah.
therapists, right? And just being able to observe dynamics. And the older I get, the more I'm finding myself just sitting back and observing first and just kind of watching everything and learning and just getting, instead of trying to force myself and force the modality and force the techniques and shout it from the rooftops, like, you don't need any of these things. You just need this and this
Yeah.
and this. So being that quiet space, that safe space, and when you're really listening with your ears and your eyes and your fingertips, there is a moment where the athlete just, or the patient just starts telling you what you need to hear. You hear the frequencies in real time coming out of their mouth when I say, explain what you're feeling with this. And they'll say it. They feel tight. They feel scared. They feel pressure. They feel it doesn't feel safe. I think about it too much. And I'm searching for the other FSM practitioner in the room to lock eyes with and be like, did you hear that? He just told us 94, 294, 13, 40, 89. This is what we have to do. And there wasn't that. So I had to just hold it inside and be like, okay, we have a plan. You gave me a lot of really great information, and this is what we're going to do.
Yeah.
And also being really grateful that I don't work in that environment, that I get to have my 2 hour window where I can take my time. And even if I had 100 machines, I would still want 2 hours because sometimes patients just need that time with you. And so I guess my long-winded comment is for the practitioners that are listening, I think if flexibility is going to be our overarching theme for today, we have to be flexible with our time. Sure, it'd be great to treat somebody every 45 minutes and have a packed day. And I just don't think that model works for some patients. I think patients, especially in this day and age, need one-on-one time to look somebody in the eye and have somebody say, it's going to be okay. I can take care of this. This stuff is pretty easy for me, actually. But so the psychotherapist part that you came in with, I think the more you practice with FSM, that is an actual big component of your practice because we create that safe space for patients to tell us the scary history that led them up to this point, the history that nobody really cared to ask about.
Or wants to hear. The patient that has gone from COVID to MCAS to SIBO, and that's what they came in with on Monday. Tuesday, it's like, and I haven't seen him in 7 years. Is that right? So, but Tuesday, it's like, tell me about what your life was like when you were a kid. What was home like? Oh, because there were pieces of it that just didn't make sense. He's healthy, he's well off, he's talented, he's smart, definitely a dopamine dude,
Yeah,
definitely a COMT,
yeah,
and anxiety is one of his complaints. And it's like, yeah, because you're not riding motorcycles right now, or jumping on the planes, or doing those, or skiing, or doing those things.
yeah,
And let me explain about that. But what was home like? And then I got the story. And then it's okay, because he already had a CustomCare and a converter, but he hadn't been using them
yeah,
because they didn't do that much. And that's
yeah.
like, he said they did it first, but then they didn't. And it's okay. So after hearing the story, I changed concussion in Vegas to running 20 minutes on 40 and 89 instead of 4 minutes,
Mm-hmm.
and 30 minutes on 81 and 109 increased secretions in the vagus instead of 8 minutes.
Yeah.
And 40 just remodeled it based on what he told me.
Yeah.
And the other thing that occurred to me as you were talking about working in that chaotic, busy environment is you don't get the stories that you get. They won't say it out loud because there's somebody they know 4 feet away.
Yeah.
And it's like they're just not allowed to
Be vulnerable.
be vulnerable.
Yeah. I think that vulnerability it's a big component with working with athletes, right? It's a big component of working with perioperative patients, right? There's a loss of control. When we are injured, we have to surrender. We cannot move the needle any faster than things are going to heal. And we can do everything right. We can eat right, sleep right, supplement right, inject all the things that could possibly expedite healing. And sometimes it doesn't move as fast as we want it to. And with that comes the fear, the frustration, the anger, resentment, guilt, grief, shame, all of it. It's completely layered. And so we don't have to be psychotherapists. Most of us are not psychotherapists. And our job is to not counsel them through this. I think like most of us, and this happened today in my house where I was very frustrated about something. I needed to just have somebody to talk to. And my husband wanted to fix it. He wanted to find the objective thing that's going to make this better. And I'm not sure that there is one right now.
I just need to vent.
I just need to vent. I just need to get this off my chest. I need to look somebody in the eye, feel connected, not feel alone. And that was what I really felt from this last trip was these stubborn injuries that didn't heal according to the timeline. There is a space, there is a connection between practitioner and patient where they should be able to process it verbally, maybe not verbally, just you get that sometimes with the patients where it just all of a sudden goes quiet. And then you look at the CustomCare and you look at what's running right now, or what could I run to help them with whatever this is, relax and balance, the concussion protocol. Maybe,
COVID in the vagus, COVID in the midbrain. It's like,
yeah.
yeah.
And so the 40 and 89 can be such a helpful frequency, in my opinion, to use before the emotional things
Always.
within the concussion protocol. Like you just said, you deviated from, okay, the concussion protocol is on, or concussion in Vegas, but maybe we need a little bit more 4089 in there as well. And I don't know what the right time frame is for that frequency just yet. 2 minutes, 10 minutes, 20 minutes. Like I don't know.
I do know for sure it's not 18 hours.
Yeah,
You
no,
do
it's
know that.
not. It's not that long. Yeah. And somewhere in the middle, right? So I think for the practitioners listening, and even for the patients that are listening, when you're giving the history to an FSM provider, and if you're an FSM provider listening to history, listen to the history, the emotional part of the history, when they say they're a 10 out of 10 in pain, but they're walking and shopping and going to the gym, they're not a 10 out of 10. Those are the perfect scenarios where you can ask more questions and you can pull
and give more information. It's like, okay, there's two parts to pain. One is how much it hurts, and one is how much you mind it. Just between us, if you're walking and talking and sitting up and chatting with me, you are not a 10. That's how much you mind it.
Yeah.
That actually tells me what the pain generators are. It's either bone or nerve. It's the only two things that hurt like that, and maybe the viscera. And then, so how much does it actually hurt as opposed to how much you mind it? Oh, that's about a 5 or a 6. Okay, so narrows it down to nerve and bone.
Yeah.
To some extent. The other thing that's really fun is when they tell you something that only people know who have been to the core or listened to the core multiple times. So the patient says, I keep injuring my hamstrings because my glutes are weak. Do you
Yeah.
remember this story? The marathon runner?
I am that person. I'm a
What?
half marathon runner who gets diagnosed with weak glutes all the time.
Yeah, and it's because you have a groin pull. So I said, it can't be that easy. And she said, what? They've been working on my glutes for 18 months. And it's like, is that sore? Ow. Okay. So we did
Yeah.
that. Oh, that's the other thing. This patient she had COVID and can't remember how long after acute COVID, but she had a stroke, blood clots, long COVID, blood clot thing, and she had a stroke. They did the MRI. It was read wrong, so they missed it. And they finally got somebody to read it. And by the time it was read, it was the tail of the hippocampus. The hippocampus in our world is part of the midbrain, and its job is to keep unconscious or subconscious memories, especially bad ones, buried. And when she had a hippocampus stroke, all these memories came flooding back from a severely abusive childhood. And oh dear. But then she said, and I can't turn my arm. Excuse me? Yeah, my whole left side is really tight. Actually, both sides are really tight, but my left side's really tight. And it's like, really? And that took me back to the patient at Cleveland Clinic that had the pons stroke that was all spastic. And I thought, the midbrain and the pons are near each other, maybe. And I didn't want to run increased secretions in the pons, which is what I ran on the patient that had the bad pons stroke at Cleveland Clinic. So for some reason, I picked 40 in the pons. A bunch of things happened. I ran it from neck to feet. First, her calves softened, and her tib anterior softened, and her quads. And then finally, I said, feel your arm. And she said, it's not, how, it turns. How did you, what? And then she said, my glasses are wrong. And it's like, let me explain about the pons.
Yeah.
9, 8, 7, 6, 5, 4, 3, 2. So every cranial nerve from 9 onward, except for smell, is in the pons. So her vision was funky for 24 hours, and she had a headache and like all sorts of things that I didn't expect. But you do something to a brain part that nobody else can do. It resolved the spasticity for 24 hours, but there were other things we had to deal with and I had to explain. And it's okay.
But you could
Yeah.
explain it though, right? And that gives
Open
them,
netter and point
yeah,
to that thing and go, how's the side of your face feel? Oh, my jaws, my face is all loose. Yeah.
right.
What do you mean? Yeah. See this page? See this cranial nerve? It does that.
Yeah.
To the people that have to do this in a 45-minute slot, it just means that you have to think faster, work faster, hope for simpler patients that are slotted in between the tricky ones so you can at least end the day more or less on time.
Yeah.
And because sometimes you really do have to see 2 patients an hour to pay
Right.
the rent.
For sure. I think, and again, being in that environment reminded me of, okay, not everybody has the same model that I have. I didn't have this model until recently either. But that's where renting custom cares, and I know not everybody likes to rent out custom cares, but that's where you can look at the questions after.
So
That's where renting custom cares or having a space in your clinic if you are worried about renting the custom care, because there is only so much maybe you can do hands-on. And in the sports course, that's why I kind of gave that model of, okay, if you have an hour, if a patient has an hour appointment, you can be with them for 30 minutes and then leave. Maybe you can run something after for them or program the custom care, tell them to take it home, put them in a different room. There's usually a workaround. So for the facility, I'm like, okay, you have 20 minutes. Here's the precision care. This is what we do in 20 minutes. Then you program something on the custom care. They go on the mat, they go stretch, they go activate, they go do something, check in with you. You have to be flexible and you have to be creative, but there's ways to do it with the 2 devices that we have.
true story.
Yeah, but
Yeah.
you're right. You have to think on your feet. But I was trying to demonstrate working on a patient with 3 machines running and having the laptop open with his machine and programming, working, programming, working, programming. And then, well, and is it optimal? No, I would love to be able to sit down with a cup of coffee and make some different programs. But if time is of the essence, you can do it all. It takes some juggling. It doesn't, you have to be able to multitask a little bit. But before we get to some of the questions, I want to talk about another patient this week, actually. A patient I'd been working with, she's an athlete for a long time, and she sees a lot of other practitioners for soft tissue work. And she had been seeing one practitioner for a while who does techniques that I personally don't agree with. I view them as traumatic,
Oh,
aggressive,
using metal or plastic implements of destruction.
or
Oh,
or elbows on places that elbows shouldn't be.
true story.
There was fear this time of, I think they did something wrong. I have pain, I have this, I have that. Do you think he messed me up forever?
Oh,
It was, I'm like, no. Soft tissue work is extremely safe. Do you feel like you've been hit by a Mack truck today? Yes. Did it do long lasting permanent damage? Highly unlikely. But even my words weren't enough. It was using 3 machines and words and movement, saying, look, now this is calming down. And now this is the strategy. And programming on the custom care, a lot of 40 and 89. And even increasing the time, those beginning frequencies that are on the concussion protocol, the first 2 lines, 90,
8-1
yeah,
200,
yeah,
970, 200.
yeah, those are there, people, in the beginning for a reason. It takes that energetic charge down a couple layers. And so it's like, oh, I feel it's working already. I'm like, and I had not even touched inflammation or torn and broken on the tissues that I needed to address. So she has a custom care. I programmed it in real time. I bumped that up by another few minutes in the beginning. Right now, this is a lot to work through, and this is really scary for you because you go to somebody that you trust to take care of your body and you leave feeling worse. And that has, for an average everyday person, maybe they get over it faster, but for a high level athlete, their body and their feelings of what they're doing is everything.
Yeah, no,
So I always say never tinker with the concussion protocol because it's beautiful as is. But maybe sometimes you give a little bit extra minutes here and there, right? So you had talked, again, reiterating 40-89 maybe first for a little bit or intermittently. I don't know.
yeah. And one of the patients I saw, her husband died just about a year ago because it was just the anniversary of his death. And she said, I feel sad. I'm just grieving. And then the more she talked, it became obvious that what she was feeling was afraid.
Yeah.
Who am I now? What do I do now? I was safe with him. And now I'm just me. So you run instead of grief, so that those last slides in the core, we talk about 970 and grief is
Yeah.
the one place you can get in trouble.
Yeah.
So for her, we did fear and worry and over concern and a little bit of anger because things weren't set up for his passing the way they should have been. Not much resentment. And then we got to grief. And the suggestion was, how about so she's in a women's group that does crocheting and she does this and she does that. And I said, how about taking a women's self-defense class? Because she feels vulnerable. She's afraid when she goes out because she was always safe with him.
Got you. Yeah.
And you walk differently when you know what to do when something happens,
Sure.
or learn to carry a cane so you have a weapon.
Sure. Let's talk about this a little bit more, actually, because you're kind of circumventing around a word again to make my parallel to the athletic community. It's confidence, right?
Yeah.
So when we are rehabbing, and this is the great part of the rehab course, is not just the manual techniques, but the patterning and the movement and the repetitions that we have to have somebody do. Confident, it's pain-free, enjoyable confidence that and repetitions in that feeling is what syncs that firing and wiring together. So right away, you unpacked a really heavy presentation of grief and sorrow and sadness. And you can filter through that and say, okay, can you expedite this healing? Probably not. But what would help bolster that is feeling empowered, right? And we all know when we feel confident and empowered, it doesn't matter the burning building that we're standing in because we know we can handle it. And so that is a fantastic piece of advice for somebody. When when I was away, we were doing some patterning and doing some really basic kindergarten movements. And athletes and a lot of people, they get off the table and they want to try to do a range of motion that's going to replicate the pain, right? They're trying to find it. And I'm like, okay, I get it. You feel fantastic right now, but we're going to pattern in this range right here. This range is super easy. I'm like, and that's why we're patterning here. It's enjoyable. It's easy. I could do this all day long. Perfect. Let's do that 10 more times. And every repetition is sending a signal back to say, that didn't hurt. That actually felt good. Let's do it again. That is where we want movement. That's where we want to live. This is great.
The same movement in the pain-free range, because they try and make it hurt again because it's always hurt. And it's like, let's not do that.
No, for now, we're just doing this. And then maybe another day we'll do this. And then we'll do all the crazy stuff that they try to do.
Bless their hearts.
I know. And I get it, right? I would probably do the same thing. You come in with pain, this is what hurts. And then after you want to prove that it feels better. But sometimes that movement that created the pain is like 12th grade. And we have to pattern in second grade. And then we move up to blah, blah, blah. And you just incrementally challenge the range, challenge the exercise, challenge the load. But we move slowly. So we had a new practitioner that we were working with who took everything kind of correspondence, distance, online, and then got to spend some time with me. And he's going to do fantastic. You know, when there's some people, you're just like, oh, you're going to do so well. I'm so excited for you, who just like get it and feel it. And I think I actually texted you that he got to feel dwarfed and feel smush. And what an experience that is as a newbie to get both. And so when we're talking about palpation and manual skills, I'm just going to tell you right off the bat, do 50% less than you were before FSM as a guidepost to start. He's like, really? I'm like, at least 50% less pressure. He's like, you can tell.
And at 20% of the pace, it's weight.
Yes.
In capital WAIT. Press, feel, wait, move.
Yep.
Yep.
Yeah.
Good advice.
Yeah. And I don't know where I was going with that, but yeah,
You're telling a story because he got to feel smush and he got to feel Dorf.
And so similarly to the patient that wants to push it, then they start to speed up and increase. It's like, no, you got this far because you were lighter and slower. And now you have to just keep staying in that, just move slowly. It will come, right? And then the next thing you know, it all turns to pudding. And they're just like, how did I do that? I'm like,
Yeah.
because you waited. Yeah. And you listened. All right, let's get to some questions.
I love her job.
I know.
I
Hi, Leaf. Hi, Jillian. Jillian, oops, sorry, but don't be sorry. That's why you're here. Have an acute compression fracture T12, running acute protocol, and 40 and 10, 4396. Patient doesn't take pain meds, but can't seem to touch the pain. I have a lot of comments.
Where is the pain? At the fracture? The other thing is in the acute fracture protocol, the frequency for bone marrow is not included in the standard fracture protocol because not all bones have marrow.
Yeah.
And messing with bone marrow makes me nervous. You take the acute fracture protocol and modify it. Actually, with an acute compression fracture at T12, I do it by hand, at least the first time in the office. And then if the patient can buy a CustomCare, then program it to include marrow because the spinal column has marrow, and across the back bilateral at T12, that's nerve. And you want to look at the x-ray and see how much compression it is. Could be nerve, but I say that, and it also could be just spastic muscles. The brain decides that this piece of spinal column should not move. So the muscles are super tight and you can't win. The cerebellum, it does not negotiate. So the muscles will relax when the fracture heals, and the fracture, depending on when you got it. So if you got it in a 4-hour window, it might be better in 3 to 4 weeks. If you got it 2 days later, it's going to be better in 6 weeks. That's just how long. Depends on how much it's been compressed. There's a huge sympathetic plexus. Huge might be an exaggeration, but there's a big sympathetic plexus at T12, L1. So there's going to be really tight thoracic paraspinals right there. And they can't take Advil, and medical physicians have become very conservative with their use of opiates. So nothing wrong with Tylenol, nothing wrong. You probably shouldn't even use compounded ketoprofen and lidocaine. And
I would also, like, we talk about RockTape all the time. When I see bilateral T12, that's where my brain went right away. The paraspinals were splinting around the area. So from a therapeutic standpoint, you don't even have to do the thick strip, but you could cut the RockTape in half and go small on either side. But sometimes that tape, that proprioceptive tape, I would probably go 2 or 3 on either side of the compression fracture up and down. So like those paraspinals just give that feedback that, hey, we're supported. Of course, RockTape does pull that fascia up a little bit too, so you're getting good circulation, which is going to help the healing. I'd also be curious to try 20 on A, pain and pressure. I actually really enjoyed that frequency with compression. So, yeah,
And if the tape isn't enough, a lot of times for a T12L1 compression fracture, which is the most common level, just a rib belt, just brace it so
yeah,
that the muscles don't have to work so hard to secure it because it's unstable. And
yeah,
there's still a spinal cord at T12,
yeah.
and the body has an opinion about that.
And also the trauma frequencies, 294 and 94, you can try that because that's what happened. There was some sort of trauma that happened there. So sometimes that can work well, especially with 396. But
And the other thing is hemorrhage. The
yeah,
fractures bleed, and the marrow is very well vascularized, so maybe even bleeding in the marrow. Yeah,
maybe. Yeah.
yeah, that's a thing.
It
That Sherry's is one of my pet because this comes up on,
This comes up all the time. So
it's
it's
driving me
coming up.
crazy.
Well, we were just talking about that. If somebody keeps asking the same question, maybe we need to structure the education better.
I don't,
I think
I
you do a good job with it. Maybe
help fix that because it is very specific. And I go over it twice. Maybe I need to go over it 7 times
maybe.
because it's only 40. Okay, I've
Yeah,
removed
that's the
all
question.
the 40s, even in the concussion in Vegas, because the patient has a cough from a potential viral infection. This is correct, right? No? Uh, if they have an infection anywhere, somewhere in their body, no 40s should be used anywhere. That is what I say because I used 40 in the cerebellum and the patient had an acute infection in their tooth. Patient has a cough from a viral infection, or we're sure it's an infection. I guess the other thing you could do is use 40 manually with a precision care with them in the office and see if it makes their cough works. That's proof of the pudding, right? Maybe that's it. It's you're actually thinking through it because the patient has, you're not removing it from every patient every time, which is what I've seen on Facebook more than once. And that makes me a little crazy. But you're sure you're actually asking a really sensible question. I'd try it in real time and see if it makes them worse. And if it's a viral infection that's causing a cough, maybe you could run viral bronchitis or common cold throat and then go ahead and treat 40 and whatever. 40 and 89. The other thing is treating treating the vagus during when the patient has an infection. The vagus suppresses the immune system. I get worried about that every now and then. On the other hand, if you have an active infection, the vagus will notify the brain that there's an active infection, and the brain will turn the vagus off faster than you can turn it on. You got very little to worry about in turning on the vagus. And so, good question, actually.
Yeah.
You?
I think where you and I go a little crazy is when we see people that are like, we should never use 40s ever, full stop.
Oh, yeah.
And there is a group, but like I said, Sherry actually thought through it, and it's not to never use it, but to use it thoughtfully or to remove it thoughtfully.
And where to use it, kind of thing.
Yeah. How often have you been in trouble using 40? Like, how many times is that one? I also have the one, and it was the dental thing that happened. It was,
It's it's an encapsulated infection that is the problem.
yeah.
The other place was on myself when I had a gallbladder infection. My
Okay.
gallbladder was actually infected, so it hurt. So I ran 40 and 50 with the gallbladder, and it got way more. painful. And it's like, I went to my GP and said, is it possible for the gallbladder to be infected? And he palpated it, did my white count, and he said, yeah, it is. How'd you know? I said, never mind. It's a thing. So here's your antibiotics. And I couldn't treat my gallbladder for 6 weeks until I could have it out. Yeah. So there's that.
Interesting. That was a good question. Do we
Yay.
have any? Oh, and Jillian wrote that she taped today. Yeah, Jillian, let us
Yay.
know if any of those things help, because I feel like compression fractures are pretty common and they're painful. And it's like anything, when you have something and you go to a doctor and we have a compression fracture, you just have to like, can't do anything. It just has to heal. And it's just like, what?
Excuse me.
Yeah, it's a hard pill to swallow.
The other thing about fractures that I found out when I fractured my shoulder is that as soon as you fracture it, as soon as you fracture anything, your vitamin D levels start to drop like a stone because the body uses vitamin D to repair the fracture.
Yeah.
So that it is not unreasonable to do 20 or 30,000 units a day of vitamin D for about 3-4 weeks, and then check the levels at the 3 or 4 week mark and see, because the body uses vitamin D. There's actually 2 papers out of OHSU here in Portland that document it.
I mean, it makes sense. It makes sense.
Yeah.
And then making sure that you're taking good vitamin D, that you're absorbing and not just like
Liquid.
Yeah.
Yeah, vitamin D as a powder just doesn't compute for me. I get it.
Yeah.
And then leaking bladder protocol, Steve, it depends on stress incontinence protocol. I'm not confident that that actually works. I think I took it out of the updated mode bank.
Oh, did we have it before?
Yeah, we did have it before, and I stopped talking about it. I think I even took it out of the core because it just didn't work. And it's because there are too many factors. So there's pelvic floor muscle strength.
Yeah.
There's the bladder sphincter. The bladder is, I've said this so many times this week to patients that it just is one of the most neurologically complex organs in the body. So motor to the bladder is sacrum. Sensory to the bladder is L3. The bladder sphincter has sympathetic and parasympathetic innervation. And then the pelvic floor helps keep it up and closed or open. And it's just, there's just too many moving parts.
Yeah. Yeah, that is a lot. And I've been seeing a lot of pelvic floor people lately. I do not do pelvic floor, but I'm working with the PT who does pelvic floor with the patient, and it is very complicated and very frustrating. And yeah, I don't have much to really add myself, unfortunately.
The pelvic floor is motor and it's innervated by somebody out there is going to know.
If Linda is on, Linda is a pelvic floor genius. Are you here, Linda?
Are you here? Where are you when we need you, Linda?
Yes, you are here, Linda. Type in and tell us all the things.
I'm pretty sure it's sacral.
She's not on today.
She's what?
She's not on.
Kevin says she's not on.
Sure.
Oh.
There's Linda.
There's Linda.
I don't see Linda. Oh, there she is. You're right.
Okay.
Maybe she doesn't want to tell. Maybe sometimes people just jump on and then they are cooking dinner or they're chopping or they're doing something and they can't actually communicate with us.
Come and go.
That's okay.
But so there's motor, then there's weakness, and then there's trauma. And then there's, oh yeah, there was that time when I had twin boys on the bathroom floor. Excuse me? Okay, that was bad.
Yeah,
So,
so many, yeah, like everything that we do, we try to go back and figure out, okay, we have this, yes, but how did we get here? What is the story that led us up to that point? And I think that is the overarching question that whether it's incontinence or weak glutes, tight hip flexors, like how did we get here? What's the story that brought us here?
on weak pelvic floor muscles, the first thing I actually do is put your hand on the desk, lift your little finger, put your elbow out. How's your thumb? Okay. So that these muscles and connective tissue, the pelvic floor connects every place in the pelvis with those muscles connect with thin bands of connective tissue. And if you're hypermobile, if your connective tissue is hypermobile and not built correctly,
Right.
the connections are not going to be strong. Oh, goody, I was right. S2 to S4. Yay. Thank you, Catherine. So and the sacrum is complicated because it's dermatomal, but the sensory and motor is different.
Yeah.
And motor to the bladder, motor to the pelvic floor, all kind of sacrum. And then, it's like we can test reflexes for nerve roots, but how do you look for a Tarlov cyst in the sacrum that's compromising nerve function? Oops. Once you've seen weird things, you can't ever not wonder about weird things.
And educate the rest of us about the weird things so that when we see it, we can say, aha, I've heard of this.
Yes. Yeah.
Now I know what to do, or at least now I know what to avoid doing,
Yeah.
which is sometimes good. And we were talking a little bit about this the other last podcast or the podcast before about scope of practice. And just because there's a frequency for something doesn't mean you should treat it. We have such a big referral network, our little FSM or a big FSM community. I love asking questions. I've never had really shame in saying, I don't know about this. But I'm going to find out. And if it's something that I can treat, then we'll try it. If not, I'll send you to somebody who can. So yeah, that's also the thing. I think because when people go to the core, I think some of that overwhelm is, oh my gosh, I haven't thought about the anatomy here since school, or I don't treat this, so I haven't thought of it that way. And it's not that you have to jump to that. It's just FSM I don't want to say forces because that's it enables you to grow as a clinician in ways that
That's a good way to put it.
yeah, because I would say it forced me to, sorry, my old dog's just,
Hi, baby. Oh, that's my dog.
yeah, it's your buddy. That's right. He's 12. He just had a
Oh,
birthday a little while ago.
getting up there, huh?
Yeah.
So's Jack. We've got a 12-year-old. Oh, that's a mirror. So you
Yeah.
don't have two of the same print.
No, thank goodness.
And there's the baby dog.
Yeah, it's the baby. I never want to say FSM forced me to do anything because that doesn't sound happy. It enabled, it allowed, it
Oh,
opened up doors,
it
it
allows.
enriched.
Yes. So when somebody says I have weak glutes, it's nobody has weak glutes. That's like
No.
it is one of the few muscles in the body that has its own dedicated motor nerve root. Nobody has weak glutes. Lots of people have abdominal surgeries, C-sections,
Yeah.
groin pulls,
Yep.
adductor strains. Lots of people have those, and those
Yep.
create adhesions in that femoral plexus, and that will inhibit. So one of the conceptual frameworks that makes FSM practitioners different is that we are aware of the difference between weak and inhibited. So this same patient that had the weak glutes and the adductors adhered to the femoral plexus also had a vastus lateralis that wouldn't fire. And so they were doing, I can't remember what they fussed at her about, but they gave her the wrong exercises. So that was the thing. But also, once we freed up the femoral plexus, the adductors, which are internal rotators, and the vastus lateralis, which is an external sort of rotator, then all of a sudden I said, oh yeah, by the way, externally rotate your foot and straighten your leg. She said, oh, my vastus lateralis fires. Yeah, it was just inhibited. It's okay.
And to take it one step further, some people will just stop at you have weak glutes or you have a weak VMO. Okay, let's unpack that. Is it weak? Is it inhibited? Why is it not firing? Starting to pull that apart. Why wouldn't our nervous system want this muscle to fire? What could be the reason? Could a nerve be adhered somewhere? Could there be an adhesion somewhere else that if you contract it, it's going to tear something? You have to, it's not just about, oh, increase secretions to the nerve. No, it's not just that. Why? What are your hypotheses, right?
It's like the FSM core turns everybody into a 3-year-old. But why? Why
And
is
then-
that?
And then by the end, you're just like, because I said so. Because that's the way it is. Just accept it. No,
It's
we
like-
don't want to say that.
It's the a patient also that said, I'm not expanding my chest muscles. Why is that? Oh, she had COVID and she coughed like crazy. And she also had bleeding because of long COVID and the clotting and whatever. So freed up her kidneys, that freed up her diaphragm, and then treated the intercostal nerves. And then all of a sudden her chest would expand because her diaphragm could move and the quadratus lumborum wasn't spastic.
And that's one of the fastest, I think that's the first avenue that I will go down if something is inhibited or not online, however you want to phrase it, anything but saying it's weak. If something is not firing the way that it should, that's what I start thinking of. If it were to contract, what would happen? What is that antagonist doing, right? So if we're thinking about the glutes extend our hip, so why doesn't that hip want to go into extension? What are the hip flexors? What would happen on the anterior side? Could there be, and I don't want to even just say tight psoas because I feel like that's been thrown around, but is there something on that anterior chain that could be adhered or scarred that going into hip extension is a bad idea? And that's what the FSM rehab class is going to help just unpack those simple kind of biomechanical concepts where if this were to happen, the cause and the effect, what would happen? And I think that can help pull you through those nuggets. And then you go back to your assessment and you're like, oh yeah, her hip flexors were actually really tight. Actually, she had a history of
Oddly enough,
something.
C-sections, abdominal surgeries, there's a spot
Endometriosis.
where blood can just drip down right
Yeah.
along that femoral nerve. And okay, every drop of blood has fibrocytes. This is the thing I'm so excited about the rehab class, because it's like the things that I do a drive-by on, like the story about the weak glutes and when did you have your groin pull, that I don't ever unpack. It's a one-time story. And it's like in the rehab class, they're going to
Take
get
those deep dives in there. Yeah.
more deep dives. I'm so excited.
Come
It's
for a
a-
swim.
Yay.
Come for a swim with Kim, the deep dives and all the things.
Yay.
Yeah, I'm so excited. Geez,
And if you ever needed an excuse to come to Costa Rica, is that the first time we're going to do it? Is in Costa Rica?
Yeah.
Oh, I'm so excited.
I know.
Yeah.
What a great environment it's going to be for
Oh my
learning.
God. It's hard to describe it until you're there. And
I've heard that's how I felt at Kona though. Like the first time I was there was, I've been to Hawaii before, but it was just a very different feeling.
yeah. And Costa Rica is that times 10. If you've, I don't know if you've ever seen Kevin during a core, like he never sits still, he never, right?
Yeah.
He fell asleep on a massage table during a break.
I love that.
That's
love
all
that
you
for
need to
Kevin.
know.
I can't wait.
It'll be fun.
All right,
Okay.
that's it. It's 4 o'clock.
Sure.
You got your reminder, sign up for Costa Rica. Come stay the extra week and play with me.
Yes.
And keep the questions coming. I shall be here next week.
And London.
Yeah.
I just sent in the deposit for London. There's a 3-day visceral. So that is, the visceral is at the end of the core is just a drive-by. And I'm taking next week and hiding out at the beach and writing a 3-day visceral that is going to be some from the advanced. And it's aimed at functional medicine, MDs, naturopaths, people that do functional and integrative medicine.
Yeah.
And it'll be a combination of core and advanced concepts so that you have what you need to do visceral care.
Yeah.
And even people like in chiropractors in wide scope states would be good candidates as well with a wide scope.
Yeah.
That it's going to be fun.
Yeah, I'm so excited for that.
Yeah.
Good job.
Okie dokie. It's 4 o'clock.
It is. Yes, FSM challenges us.
Yay.
Love it.
Opens doors.
Doors.
FSM opens doors. I like that.
Yeah.
It's good.
Hard to believe until it's impossible to ignore.
Hard to believe until it's impossible to ignore. That has got to be our new logo. We'll work on a new t-shirt.
Yeah.
That'll be fun.
Yeah, I like that. All right, everybody. Thanks for coming. See you next week.
See you next week. Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.